Hi, everyone. My name is Rachel Jackson, and I'm the president and founder of Rachel's Remedies, LLC, which is a women's health company. And I really appreciate your time, and thank you for allowing me to be here today. I have been a corporate attorney for about 17 years, and I had 2 children, and while I was nursing my children, I experienced very painful and common breastfeeding conditions. And it was during that time that I realized there was no adequate remedy on the market. So I invented Rachel's Remedy breastfeeding relief packs to solve that problem, and that's what I'm here to talk to you about today. Breast milk is the gold standard for infant nutrition. The American Academy of Pediatrics recommends that all infants receive breast milk as the best source of nutrition, and that women breastfeed for 6 months exclusively and then up to at least 1 year. It provides improved immune defenses, gastrointestinal function, neurological development, and numerous other proven benefits. Many infants in the neonatal intensive care unit are unable to feed at the breast, and their mothers must initially express their milk. Many full-term babies are unable to feed at the breast as well for various reasons, medical reasons, and also a big reason is mothers returning to the workforce. Pump express breast milk is the only option for these babies. Pursuant to the journal Pediatrics, if women breastfed according to the American Academy of Pediatrics recommendations of 6 months of exclusive breastfeeding, the U.S. could save $13 billion annually in healthcare costs alone just for the baby. That doesn't even include the mother. Yet only 22% of women in the United States breastfeed pursuant to those guidelines. This is because a majority of women quit breastfeeding due to low milk supply and very common and painful conditions like I had, such as engorgement, clogged milk ducts, and mastitis. Mastitis is, for those who may not know, is an inflammation of the breast that can become very serious and require antibiotics and hospitalization. Failure to breastfeed pursuant to the American Academy of Pediatrics recommendations drives enormous short and long-term health costs for mothers and babies. Moist heat is one of the most commonly recommended and one of the most effective treatments for these problems. Warm water compress applications prior to breastfeeding or pumping have been proven to improve vascular tone, which gets blood flowing, but it also gets milk flowing, which is why it's so important for some women to use moist heat before pumping. To increase circulation, it produces oxytocin, which is a hormone that triggers milk letdown. And it also prevents the stasis of milk, and that's when milk stays in one place and can cause a clog, which could eventually become mastitis. It also helps to encourage letdown. Studies have shown that the amount of breast milk obtained after applying moist heat to the breast is significantly higher than obtained from non-warmed breasts. Mother-baby separation can cause a very poor letdown reflex, so mothers with babies in the neonatal intensive care unit have a particularly hard time producing milk and also getting that milk that they produce to actually come out, literally. Until now, there has been no effective solution on the market to treat these conditions. Current moist heat treatments are impractical and are impossible to use in any public setting. I have submitted 2 letters that you'll have in your materials. One is from a doctor in support of our request, and another is from an international board certified lactation consultant. And her name is Cynthia Oppenheimer. In that letter, she talks about all the complications I just talked to being very common, and that she recommends moist heat for lactating moms. And she wrote, since moist heat rather than dry heat is desired, my recommendations are to hand express while leaning over and into a large bowl of very warm water, applying dripping wet washcloths, and taking many warm showers to relieve these problems. So you can imagine women going back to work or functioning or trying to take care of their children in any manner or do anything, having an impossibility with these treatments. So our solution is Rachel's Remedy breastfeeding relief packs. They are a wearable, hands-free moist heat treatment They're the only FDA-cleared treatment for these indications on the market, and they consist of a flaxseed-filled pillow as our heating element, and this has a recess for the nipple area, which is important for sensitivity reasons. And then that goes into a waterproof pouch. The waterproof pouch is part of what makes this different from anything else on the market. And it protects clothes from getting wet so that it makes it a wearable device. And it also protects the flaxseed from being contaminated with milk. And it has a removable cloth for moistening. And this is what delivers the true moist heat. This goes under hot water, gets reattached, and then women can wear it in their bra anywhere, at home, at the hospital, at work. And it's used right before pumping or nursing. It can help to encourage that letdown and increase the milk supply. Does anyone want to see this? I can bring it down. Rachel's Remedy, we believe that Rachel's Remedy is not categorized with like products in code A9273. Existing code A9273 includes hot water bottles, ice caps, heat and cold wraps. A9273 does not incorporate the additional components that take Rachel's Remedy out of the heat wrap category and into a breast pump or breastfeeding accessory category, such as the removable moistening layer or the waterproof pouch that makes it an actual wearable device. Products under A9273, such as water bottles and heat wraps, are not recommended for breastfeeding purposes because moist heat, like with our removable moistening cloth, is required to actually penetrate the skin and stimulate milk production. A9273 does not include like products to Rachel's Remedy, and Rachel's Remedy is 3 or 4 times more expensive to manufacture than, say, a hot water bottle or like products in that category. Rachel's Remedy should be categorized with like products, such as breast pump accessories, with codes A4281 through 4286. A new code, certainly assigned around those other products. Breastfeeding women are the only group that will be using Rachel's Remedy, and the most efficient way to process claims relating to breastfeeding issues is to categorize it with breastfeeding and breast pump accessories. Rachel's Remedy fits all of the criteria for revising the HCPCS coding system, standardized coding to ensure uniform reporting of services on claims and meaningful data collection. Categorizing Rachel's Remedy with breast pump accessories will place it with like products and will support the meaningful data collection and standardized coding goals of the coding system. Thank you very much for your time. Does anyone have any questions? Yes?
So you mentioned, I think, that this has a waterproof cover?
Yes.
Correct? So how does the moist heat that's inside of the waterproof cover penetrate the skin?
That's a good question. The waterproof pouch is here, and the flaxseed pillow, which delivers the heating element is inside that pillow, but the moist layer is on the outside. So that's what goes against the skin and delivers the true moist heat.
So what gets run under the hot water then?
What? I'm sorry, what?
Well, you said it's run under hot water to
Right.
heat it. So is it the external small white thing?
It is. We call this the moistening layer, which is what gives the true moist heat. So this goes under hot water,
Yep.
gets reattached to the outside, and then this goes in the microwave. And so that's what keeps it warm, because
Okay.
doctors and lactation consultants recommend 20 minutes minimum of moist
I gotcha.
heat prior to
And so
pumping.
what's in the bag in the middle?
In the bag is flaxseed. It's an all-natural treatment because
And
women
so
are
the flaxseed gets heated up in the microwave.
Right.
That becomes your heat source.
Yes.
You put it in a waterproof bag. You wet the other thing with hot water
Right.
to make it warm.
Exactly.
And then the flaxseed thing keeps the moist thing warm
Right.
for a longer period of time.
Exactly.
Thank you.
Thank you. And that brings me to one thing I forgot to mention is that, especially for women going back to work, often get 20 minutes for breast pumping, and it's really not enough. But then to add treatment prior to that makes it impossible. So with these, they can wear these without being noticed, and they can increase their milk supply and encourage that letdown reflex without having to take additional time out of work. So thank you very much.
Agenda item number 12, application number 17.103, a request to establish 2 new Level 2 HCPCS codes, as well as to revise 2 existing Level 2 codes, and efforts to distinguish hydrophilic-coated intermittent urinary catheters from the non-coded versions. Our primary speaker is Dr. C. Lowell Parsons.
Good afternoon. It's hard to follow something like that. Catheters aren't the sexiest thing in the world to talk about. I am Lowell Parsons. I'm a urologist. I'm a professor of surgery / urology at the University of California, San Diego. I've been there my whole career. And I have a rather intense interest in hydrophilic coatings of the bladder and the urethra. I've done my basic and clinical research on that my whole career. And we've learned a lot about how the bladder and urethra function because of those hydrophilic coatings. They impart the resistance to infection, the incredible resistance that the human bladder does have. And we also know if they injure them, then things leak into the bladder wall, you get a lot of bladder symptoms. And that's led me to my other big clinical interest, which is interstitial cystitis. I don't know if anybody here knows about it, but about 25% of women have it. About 5 to 8% have a very significant problem with it, requires a lot of catheterization. And I put, well over 1,000 catheters into bladders of patients with interstitial cystitis. And I want to talk about what type of catheter you use. There are 2 basic catheters out there. There are hydrophilic coated catheters and there are uncoated catheters. And we're here because go forward here. We're here because of getting a code to separate them. Currently, the 2 catheters are combined into 1 code. And the CMS has felt like there was no need to separate them. And I think that there's a big clinical need. And I first started using a hydrophilic catheter when the first one became available in a Foley about 1980. And that's the only thing I put into the bladder with a Foley catheter is because it's hydrophilic coated because it's so well tolerated by the urethra. So we're proposing 2 codes to separate the hydrophilic from the non-hydrophilic coated catheter. Currently, there are 2 types of straight catheters that are used to empty the bladder. Someone already spoke about it earlier. The straight catheter for females primarily, also males, and a curved tip catheter called the Coude catheter that goes into the male urethra to help navigate the prostatic urethra. So there are 2 codes for whether it's a Coude tip or straight, but that includes the coated and the uncoated catheters, and I'll come back to the importance clinically. And as I stated, right now, they're lumped together, and so we would like to disengage that. And I think this is a good example of, if you go to the FDA with a new device, you say there are predicate devices like a catheter, ours is the same. I think we have some predicate codes here, CMS codes. And if you look at it, I have them grouped. There are basically 2 catheters, silicone versus latex. And whether it comes with an insertion tray, with or without a drainage bag, or you just got the catheter alone. That's what all the different codes are for. But the bottom line is, no matter what you do, there's always the 2 catheters. So you code latex versus silicone separately. This is a critical distinction because latex allergies can be life-threatening. You have to have an alternative. You can coat the latex catheter, silicone, hydrophilic, and a hydrophilic latex catheter is a wonderful catheter. But you have to have a second one, an option for the patients that have allergies. And so silicone is used. Truth be told, the best catheter to use is latex. It's a stronger substance. The catheter wall's thinner, the lumen's bigger, drains better, and it goes into urethra better, and the balloons don't break. Latex is a very strong balloon. Silicone is a polymer that when you inflate it, it doesn't have an even distribution of the pressure, balloons out, and they rupture, which can be a real trauma to us if we have a fresh patient post-op from a radical prostatectomy and the catheter falls out of the urethra, could necessitate a take back to the OR. So it's important. I think the already code for the two different types of catheter here, which have a clinical distinction between the two of them, latex versus silicone, to overcome the allergy issue. Another issue that's important is that currently when you lump the two catheters that are available, the coated and the uncoated, the hydrophilic coated, together, you have to have for the uncoated a lubricant. I don't think very many physicians would put, or patients would put catheters under their bladder without lubricant. It would be pretty poorly tolerated. And so you have to have a separate lubricant dispensed. So when you write a prescription currently, and we have electronic records at our institution, we use mostly electronic prescriptions, but for catheters, we have to handwrite it. If I want a hydrophilic coated catheter, which I prefer, and I'll talk about the differences shortly, then I have to really foster that through the system, because when it goes to the distributor or the supplier, they have an option to trade out for an uncoated catheter, and they get rewarded because they put in a lubricant, so the compensation goes up, and that's a benefit to them. And another problem is if we start them out on the right catheter, when the prescription rolls over, it could also trigger a code rather than the catheter that I want, which is hydrophilic coated. And that's really critical for my patients, because patients with interstitial cystitis have very tender urethras, and they do not tolerate uncoated catheters. So what is the difference between a coated and an uncoated catheter? I know there was a pointer here. That's okay. But if you look at bullet point number 2, the difference is you put a hydrophilic polymer on the surface of the catheter from the hub to the tip. It's completely coated. There are no skip areas. It's very slimy. It's very slippery. The urethra is similarly hydrophilic coated. When it goes in, the friction is greatly reduced, the discomfort's greatly reduced, and it's much easier to get the catheter in. It also causes less trauma to the urethra, and for people who are doing it day in and day out for years, the trauma can add up to urethral injury, stricture, and scar formation. That's bad. And that's one of the bad complications of not using a coated catheter. The uncoated ones, they need to have a lubricant, so you have to also prescribe lubricant with them. There's some risk of contamination. Some physicians' offices won't, they'll just buy the catheters and use their own lubricant, and they'll reuse a tube of lubricant for economic reasons. So the bottom line is if it comes already pre-coated, that's a big difference. But here's the real difference. It's the clinical activity of the product. There are 3 major issues you're concerned about: infection, urethral trauma, and inflammation, which can lead to stricture and scar formation. That's the devastating one. If they're doing it 4 or 5 times a day for 15 years, it can be a problem. And also discomfort. These are the issues. Here's some of the peer-reviewed literature. The first one on the left is a study of 224 people with spinal cord injury in 15 centers. 21% lower incidence of nosocomial infections. This has been done in different studies. It's very important. If you want to talk about cost issues, well, that's a significant cost issue. Some of those nosocomial infections may require hospitalization. And the other important point they found is if you start using a catheter that's coated and uncoated, to the time period towards the first infection is greatly prolonged if you use a coated catheter. So it causes much less urethral trauma, and that urethral mucus or its hydrophilic coating is an important antibacterial defense mechanism. So that is a key issue. And then the Cochrane study on the right column showed that there's 64% infection rate versus 54%. That's a significant reduction. And consistently, that's what you see when you use these catheters. Now here's the one that's the biggest issue for me. A lot of you in this audience are going to require catheterization probably in your lifetimes. Maybe you've already had it, but it could occur several times. And discomfort, you can imagine putting in a catheter is an uncomfortable process, especially in males which have a longer sphincter and it's a more traumatic issue. So 93% of males, they put 40 male volunteers agreed to catheterization with and without a coded catheter. That's a nice study if you can get people talked into it. 93% of the patients preferred the coded catheter, and I think that's very important. And in another study, putting catheters into patients who had bladder cancer receiving installations of medications, you had about a 40% reduction in discomfort. But roll it into my patients. I have probably put 1,000 catheters into 1,000 different patients with interstitial cystitis in the last 15 years. And I've tried all sorts of catheters. There is no way that we would use an uncoated catheter. Patients greatly, this process of having a 10-year urethra greatly increases the pain and the discomfort associated with an uncoated catheter. And so one time I took a large sample of uncoated catheters from a manufacturer to try in the clinic, came back several days later, asked the nurses where they were. They said, well, they tried it on 3 patients. They tolerated them so poorly they threw them all away. And so I think that the point I'm trying to make is that there's good data and good evidence to show there's a big difference between coated and uncoated catheters. Big clinical difference. And that's why I think separate codes are needed. And we're asking for 2 codes, one obviously for the straight catheter and one for the Coudet tip as an alternative. So I would summarize, if you look at bullet point number 2, if you do this, and you have different codes, you could even follow. You have a huge database then, because you could look at coded and uncoated catheters for UTIs and for the long-term complication of strictures and really keep a handle on what's going on. And I think that the third bullet point about the physicians. As a physician, I want to make sure my patients get the catheter that I prescribe. And there's been more than one occasion when the patients did not get the right catheter, especially on renewal. And they get them by the month, and they get an urgent call because they catheterize 5 times a day to empty their bladder, and they don't have any catheters that they can use. And fortunately, I have to admit, reps will go out on nights and weekends to do emergency deliveries of catheters. So I think that's a big issue. The bottom line is for the patient. It's all about the patient. They do much better in terms of discomfort, infection, and urethral trauma and scarring with a coated catheter versus uncoated. So hydrophilic catheters now have taken over in urology, whether it be to the bladder, from the bladder to the kidney, and we even have guide wires to get past the ureteral stone that are hydrophilic coated. They're called slide wires because they slide right up so much more easily and cause so much less trauma. So that is basically all that I have to say, and if there are any questions, I'd be happy to answer them. We have a speaker?
Gail Daubert.
Hi. My name is Gail Daubert. I'm a nurse and an attorney, and here today on behalf of Coloplast, one of the manufacturers of both the coated and hydrophilic catheters and a variety of different things. I think Dr. Parsons did an excellent job sort of outlining the clinical differences related to the 2 catheters, as well as the benefit of separating and distinguishing these products with different codes and highlighting the ability of then researchers or healthcare providers from following and understanding, for example, when a patient gets a urinary tract infection as a result of changing the catheters. So for example, if we followed them and looked at the number of months that they received coated catheters and then if they were switched to uncoated, and we were able to track that back and note that, well, the patient had just started using uncoated catheters, was now going to the restroom and having to open up the lubricant and, balance everything in the toilet stall and then inserting them and, was not able to do that in such a clean environment and developed a urinary tract infection. So having the distinguishing codes and allowing the physician's prescription to be dispensed as written might eliminate that, or it would certainly allow and facilitate tracking of those outcomes. I'd just like to make a few other points. the American Academy of Pediatric Urologists is in support of this recommendation, as well as the Spina Bifida Association and United Spinal. I believe they should have all submitted statements to you. If not, you should be receiving them by the end of the day. There's a great deal of interest in having these separated, and I think, as Dr. Parsons also pointed out, seems sort of, listening to Joel Kaiser today talk about exploding codes and imploding codes, I thought that was such an apt description. So I was trying to figure out what happened here, because it appears as if we had codes for indwelling catheters that distinguish the coded, and then they just don't specify non-coded catheters. And then when it came time for establishing codes for intermittent catheter, I guess we just imploded the catheters, but still somehow we have exploded the lubricant, because, as Dr. Parsons noted, on the uncoded, you also have to separately obtain the lubricant. So I'm trying to figure out what his description of this situation would be. And I think that clearly, having set the precedent of distinguishing indwelling catheters that have a coating from those that don't have a coating makes sense, and to carry it on through. And then perhaps the better approach, although we didn't recommend this, might be to implode the uncoated and the lubricant together, and then have the hydrophilic, which is already coated, separately, because you're always going to use the lubricant with an uncoated catheter, but you wouldn't with the hydrophilic catheter. So let's explode the two different types of catheters and implode the lubricant with the uncoated catheter, and that would be, I think, a good thing and make it much simpler for patients, make sure they had access to this. And I'd just like to thank you for your attention.
Questions? If not, I make one more point that you may not realize. When we put the lubricant on a catheter, it really isn't fixed to the catheter. It's not really on the catheter. So when you put the catheter into the urethra, it's not a PVC pipe. It's closed. So when you put it in, the lubricant gets trapped in the distal part of the catheter by the urethra. It just pulls it right off the catheter. So the last 2/3 of the urethra is exposed to a catheter that has very little lubricant on it, and that's where it causes the most damage to the urethra when you insert it. Thank you.
All right. Agenda item number 13, we have several items here. Application number 17.105, request to revise existing level 2 HCPCS codes L8618 and L8628 to include auditory osseointegrated implant devices. Okay. Then we have application number 17.106, request to revise existing level 2 HCPCS code L8624. And then our final request for this agenda item is application number 17.107, which is a request to establish a new level 2 HCPCS code to identify the BiHi 5 Superpower Actuator Unit. Our primary speaker is Ms. Kalisha Bird.
Hello, my name is Kalisha Barrett, and I am here on behalf of the applicant, Cochlear Americas, where I am employed by them in their Health Economics and Reimbursement Department as their health manager. Let's see. All right, so we'll start by explaining that Cochlear does oppose the first preliminary coding recommendation. As our understanding, there would be a revision to the existing auditory osseointegrated implant code, which would exclude the transducer and actuator replacement component. And Cochlear does disagree with this as the part of the change in the code, primarily because the actuator and transducer are components of every auditory also integrated implant, and we'll go into that a little bit more. So that does make us disagree also with backing out the payment from that specific code, again, because this is a part of every auditory also integrated implant when it comes to the sound processor. And Cochlear's request basically that there's no change that be made to the existing code for L8691, as it is currently applicable to most of the Bahas that are out on the market now. And that would require a change in the way that the current billing needs to happen for all of the auditory also integrated sound processors. Excluding that transducer and actuator component does mean that there would create a void in the current payment where we would have to revert to a miscellaneous coding option, the L9900, for all of the traditional auditory also integrated implants. And so the recommended revision would eliminate the ability for the existing AOIs to bill for this L8691 code because of the backing out of the transducer and actuator component. As it stands right now, most of the AOIs that are on the market are considered to be single integrated components. And as I'll show you in one of the new Baha Superpower, which we asked for the new code, this is now not a single component, it is two separate components. And that's why we are asking for a new code. And so Cochlear's specific actuator request that you'll see has taken the existing cochlear implant technology and paired it with the Baha technology. In the past, again, as I mentioned, and I'll kind of go forward so we can see a visual of it. All right, so in the past, and sorry, there's not a pointer, but on the first two over left where it says Baha 5 and Baha 5 Power, as you can see, there are actuator and transducers in these single integrated components. So it's one sound processor. And the far right, for Baha Superpower, the application that we are submitting, we have broken those components apart. So it's now not one single component, it's now two. You can see the ear level component, and then the actuator and transducer has been broken apart, and I'll explain to you from an engineering perspective why we had to do that. And that's why we're asking for that separate component. What you'll see here is that all AOIs have a transducer and actuator. It's a part of every sound processor, and not just from ours, but in the industry of all auditory also integrated implants. But what you will notice is that not all AOIs have this component separated out. And that is very important to understanding why we are asking for this specific code. The patients with this specific hearing loss that would be applicable for the Baha Super 5 Superpower, they require a stronger power and a higher gain. And the only way to obtain that is to separate the microphone The only way to do that is to separate the microphone, which is on the left side, from the transducer and actuator. And I do have an example, because this is our component. It's like if you take a microphone and you put it near a speaker box. If you do that, you will have feedback. And so the point of separating it is so that we don't get that feedback. And we have to do that from an engineering perspective in order to gain additional power that the patients need, as well as to get the appropriate gain that they're able to provide when you separate the two. And I'll take that off because we're close to a microphone, and that's not going to be a pleasant sound. So the Baha Superpower provides a true headwear solution for patients. And again, by separating these two, we're able to obtain a more powerful gain, which equals into a better speech understanding and sound quality for these particular patients that have a worse hearing loss than a traditional patient that might need an auditory oscillated implant. When we separate the two, and you can see in the picture here, what we're doing is decoupling that microphone and the transducer, which is a more powerful transducer. And it is powered also by the bottom portion, which is the more powerful battery that is giving it the extra gain. And so the component that we are asking for is a separate code for the actuator transducer, because this model is different from your the traditional AOIs, and because it has to be decoupled for this particular patient population. What our concern is the way that the revision to the existing AOI code is that it is going to make it, it's not going to give us the ability to use that existing code to bill for any of the existing AOIs that are currently on the market. So in conclusion, unlike any of the typical Baja sound processors that are out there, the Superpower has a very different design from our standard AOIs. And what we have done, as I mentioned, is that we've broken out your traditional single component unit into two different components, where now there is a behind the ear component as well as a decoupled actuator and transducer part. And Cochlear does support the establishment, which was the recommendation number 2, the establishment of a new code for the transducer actuator for the replacement component for that going forward. Any questions? And was there a point of clarification?
So how is it that using the two codes, one for the transducer and another one for the device, if you use those together, if they come together, or if you use the two codes, if it's decoupled, then either way somebody's still getting the device and the transducer. So how is it that the proposed coding solution wouldn't work?
I guess, are you asking how would it work if you use the two codes together? Is that what your question is exactly?
Thought you were suggesting that it wouldn't work if you use the two codes
Yes.
together to describe the Baja Superpower because it's decoupled.
Yeah, our concern is that the way that the revision is written in that code is that it says that the actuator is not included in the revision. And so our concern is that when would we use that particular code, and we're not sure that it would fall into the coding guidelines, because all of the replacement codes for an AOI, for the traditional AOIs, have a transducer actuator as a part of the unit.
Oh, sorry, I have one more question, sorry. In line with what Cindy said, can you comment on billing both codes, both the transducer as well as the sound processor when you have an integrated single sound processor?
Yes, I think that our interpretation of that is because there is no because you are requesting for the actuator and transducer to be eliminated from that code, our concern is that it would not fit the appropriate description for what a traditional single component would have. Anytime that we replace a single component, the actuator is just one piece. So the actuator and transducer is a part of this existing device. Whereas in the new one, there's two separate components. So it makes sense to us to say that the actuator needs to be replaced and the rest of the sound processor. But our concern is that this unit now, when you're saying that you're going to have to use two codes, we're not sure that the regular or the pre-existing L8691 code would be applicable, because we wouldn't just replace the transducer, we would replace the entire system. So if the recommendation would be that we are allowed to use both codes, then maybe the recommendation from us to you would be a clarification and that coding update, because our interpretation of it was that you would not be able to use it any longer.
Oh.
Does that make sense?
Yes, I see. Okay, thanks.
Thank you.
Okay, so on to agenda item number 14, which is application number 17.108. It's a request to establish a new level 2 HCPCS code to identify the Osher movable hyperbaric membrane. There is no primary speaker and no secondary speaker. Are there any questions or comments? Agenda item number 15, application number 17.113, which is a request to establish a new level 2 HCPCS code to identify the Ziva. Our primary speaker is Dr. Aileen Caceres. Okay, is Gabrielle Pennington here?
Yeah, but Dr. Caceres will be the primary speaker as planned.
Oh, okay. She's coming?
She might not make it in. She has to leave the flight. So, Dr. Caceres.
Oh, you're here. Okay, okay.
Good afternoon, everyone. I guess I'll start the introduction as they project. My name is Dr. Aileen Caceres, and I am a minimally invasive gynecologic and robotic surgeon. I'm also associate professor at UCF College of Medicine in Orlando in the Department of OBGYN. And today I would like to discuss our proposal with the Ziva product. Forward. I am just a consultant and I use the product in my office. Is this for the forward?
Yes.
Okay. So I'd like to introduce the product, and I actually brought the product with me. Thank you, Gabrielle. And I want to tell you that this is an FDA-approved belt that is adjustable and wearable, and it gives pressure to the pelvic girdle in order to give the ligaments during menstrual cycles a more stabilized force. And I'm going to expand on that in just a minute. So women who complain of pelvic pain or chronic pelvic pain, or who have episodes of dysmenorrhea associated with endometriosis, have an increase or a flux in hormonal instability, primarily with progesterone. The thought process is that the ligaments become very relaxed. And in this relaxation, if we provide a product such as the Ziva, we help to bring the pelvic girdle together with a more stabilized force. And this can help us be the first attempt to actually bring patients to deal with their pain in a conservative manner versus having to go to surgery or take out medications. The proposal today is that instead of being a supply code, that we actually get a level 2 code for the device. And I'll give you some background information on why we're thinking this. So dysmenorrhea, and I'm speaking about primary dysmenorrhea, is the common cause of most gynecologic visits. And I think everyone in this room has been confronted by either a family member or a daughter with significant pain during menstrual cycles. 1 out of 4 women will experience this throughout their lifespan. The causes can be variable. And the majority of women will actually present with this very early in their childhood and may not even know it. And it may be present during their first menstrual cycle. What we know, especially, is that the World Health Organization has actually recognized dysmenorrhea as a debilitating force, in that it can affect up to 12 to 14% of women worldwide. We also know that dysmenorrhea can be associated with significant loss from school, significant loss from work as women get older, and significant loss in quality of life. So even though we have a very high prevalence as a gynecologist, when women come to our offices, we try to think of every available thing that we can give. And one of the medications that we give women are usually NSAIDs, which is the beginning of a journey of attempting to cure a disease that may not be fully understood. Furthermore, secondary dysmenorrhea is actually caused by a condition called endometriosis. And endometriosis occurs when the glands that are inside of the lining of the uterus implant on the outside of the pelvis. So if you can imagine, you're not just having a menstrual cycle inside the lining, you're now having a menstrual cycle outside the lining. So what happens? Women can be in debilitating pain all month long. They can be in debilitating pain a week before their menstrual cycle. And this can contribute significantly to a loss of work, also to infertility. As a matter of fact, endometriosis is the leading cause of infertility in reproductive age women, especially starting from the ages of 15 to about 26 to 35 years of age. What we understand is that when we have uncontrolled menstrual cycles, you have a dysregulation of prostaglandin release. And that prostaglandin release is what's causing a lot of contractions in that pelvis. And by reintroducing a concept such as the Ziva belt, we can actually think about creating a stabilizing modality in the pelvis to help with the laxity of those muscles. As a matter of fact, a lot of times women won't respond to primary therapy with NSAIDs, which are non-inflammatories, with birth control, which is usually the second line of therapy. And sometimes we get so desperate because we don't know what to offer women that they'll either be opiate use or surgical intervention. And I'll tell you, as a primary surgeon, that sometimes we take women to surgery with extensive excision of endometriosis, and women will have recurrences 3 months later. So, why consider Ziva? I actually became very involved because it gave my patients an option to actually be able to have something that was safe, non-invasive, did not require any medications. And why is that? NSAIDs over a long period of time are going to give you an increased risk of GI disease or gastritis. It can also give you some liver influences as well. Birth control or oral contraceptives are a phenomenal option, but sometimes they can be limited in women who have thromboembolic states. Also, it can increase the risk of stroke as your patients get older. Opiate use, as we all know, we want to get patients away from opiates. We don't want patients to be on long-term opiate use if we can avoid it. And then I can tell you as a surgeon, I love to do surgery, but if I can prevent taking someone to surgery that I can cure with an orthotic device, that would be amazing and impressive for me. So Ziva, I believe, will address the primary treatment of dysmenorrhea that has not responded to therapy, or you can just start the patient with the belt from the very beginning, especially if you're suspicious of endometriosis. The other very important concept with endometriosis related to surgery is that up to 40% of lesions when you go to the operating room are not seen. So women are undergoing diagnostic laparoscopies and we are not seeing these lesions, therefore not offering appropriate treatment at that time. So just a little bit of review. Most women that we are targeting are going to be in the health insurance capture arena, and we feel that by changing the code, we can make it accessible and available as a potential first-line treatment. Furthermore, the division, as you can see here, in terms of private insurance, Medicaid, and Medicare, can also be equally divided. The components are actually quite unique, and they're unique because I actually have this in my office displayed, and patients ask us all the time. The belt is very sturdy. The beautiful thing, it's adjustable because every pelvis is not created equally. So you can actually fit the patient, have the patient lay down for at least 15, 20 minutes and see how that belt can help with their problem. If it aggravates the pain, let's lessen the belt. Let's actually move it around a little bit. So it can actually help with stabilizing the hip bones. One concept of endometriosis is that implants actually go on the uterosacral ligament that's connected to the sacral promontory. So a lot of women will complain not only of dysmenorrhea, but back pain because there's such a pull on those ligaments. So the belt can help bring those ligaments closer together. So Changing the code to a level 2 not only will increase access, but it will increase the orthotic position of treating endometriosis. As a matter of fact, we actually have a surgery called presacral neurectomy, where we go in and we find the presacral nerves on the sacral promontory and we destroy them in hopes in women who have significant dysmenorrhea that doesn't respond to anything that they can do better. But unfortunately enough, there is significant bowel issues and urinary problems because you're destroying some very vital nerves that control those organs. So in summary, the goal for today was to consider revision instead of a supply code, that we consider a code that is a level 2, that we can make accessible and available, non-intrusive, non-invasive, possible first treatment for dysmenorrhea expanded to endometriosis, and give women an option, at least additional option that they can choose from. Thank you. If you have any questions? What now?
Yeah, sure. Yep, thank you. Okay. Mr. Stephen Lee?
Thank you for having us here. We really appreciate the opportunity to address you all and hopefully address some of our concerns. Again, I'm Dr. Stephen Lee. I'm a chiropractor down in Sarasota, Florida, and I am the inventor of the Ziva device. I have personally no vested financial interest in this. However, secondarily, we put the company name in my wife, so as long as she doesn't leave me, I do have some financial interest in this. So I guess I'm here to speak a little bit more about the science behind it, the research that we did with Ziva. This has been going on for about 7 or 8 years that we've been working on this. And initially I did my own research, which really doesn't hold much water because I'm the inventor and who's going to believe me? So we wanted to, first I did my research and I showed that it's very efficacious. We saw lots of reduction in the pain. And so I approached a local physician, OBGYN in Sarasota, Florida, and we got an IRB sanctioned study approved, and the results of that study were such. 90% of the patients didn't require any pain medication during their cycle after they used the Ziva device. So that's 90% used no medication. 80% reported that when their cramps did return at a later time, they weren't as severe and they were able to just go about their day. 70% reported the Ziva device alleviated back pain, as Dr. Kacharis alluded to. Each patient verbalized the device was comfortable and easy to use. An average decrease in pain was about 4.57 points on a 0 to 10 scale. There were no adverse effects. There were no side effects. And not only did it help women who have menstrual cramp pain, they had ovulation pain. So Mittelschmerz is obviously ovulation pain. It also helped with that as well. 80% of the people would reuse it. And so basically, the U.S. Census Bureau and all the research that we've done, there's about 43 million women in this country that suffer from menstrual cramp pain. 15% of them suffer so bad that they miss work and miss school. That's 7 million women every year missing school, missing work, at a cost of $2,600 to $3,600 to the company every year for these people missing work. So this is where we're at. Questions?
Hi, thank you.
I have a question.
No, go ahead.
You go first.
I just want, I'm not sure who to direct this to, but
Sure.
If the issue is laxity, is there no physical therapy-based relief of this? Because we are pretty familiar with menstrual cramps and some of the things that can alleviate that. And then my second question was, I heard the word cure somewhere, and I just wanted to make sure that's what you meant, that this cures
the
No,
problem?
we're not mentioning that we're curing any
No,
disease. We're allowed to treat the pain associated with menstrual cramps. And so there are many, many therapies out there, pharmacological, there's some non-pharmacological, some physical therapy, other types of things that, there's NSAIDs that help people. Some people already are fine with what they're doing, but like I said, there's already 7 million women are missing out on work, which means they're already doing things and they're not getting helped. And this has shown that 90% of the people that use the Ziva device didn't need to go to NSAIDs. They didn't need to do other things. So we're not saying this is going to be all things, all people. If people are happy with what they're doing, that's fine. But this extends the reach of somebody without having to go to opioids. I could sit here and talk to you guys all day about the anecdotal, the patients that roll through everybody's offices that are so horrible with these cramps, fathers carrying kids out of school and balled up and taking them home. This is just something that's non-invasive, compresses the pelvis, releases the pressure and tension placed on the uterus, either in the abdomen, the back, the sides. There's many different places where women will experience their pain and get in the lower abdomen and their hips, they get in their back. We've had people have leg pain. The Ziva device, through the compression, either directs inhibition of the proprioceptor or the nociceptors, the pain sensation, or through the relaxation of the ligaments and allowing the contraction of the uterus to occur naturally is where it happens. But in no way, shape, or form we're saying we're curing a disease. We are just simply a pain relief.
And, I'm sorry.
Yeah.
Yes, I have it here. Can I add something else to that? In terms of physical therapy, that was an excellent question. So that will be one of our first modalities as well to try. But to sustain the physical therapy result, we've been using the Ziva belt afterwards so that they can get longer relief for longer periods of time.
I have a follow. Has this been compared to any other mechanical devices?
Not to my knowledge that there's any available, quite honestly. I think the closest we come to is physical therapy, and the physical therapists feel pretty devastated at times when it's just a vicious cycle. You get relief for a little bit of time, and then they go back to surgery, or they'll go back to medications. But in my experience, this is given probably the most benefit longer term.
Have you tried sacroiliac belts?
Sure.
We've had a lot of the skeptics in me being a chiropractor talking about menstrual cramps is kind of ironic, but I have 6 daughters, so there's a necessity for me to invent this thing. So, and I'll help you with that. That's one of the biggest challenges is we're handing somebody something. If I hand somebody a pill bottle, I say, I have a new drug, take these, you can read the instructions. We know what to look for. Do I take it with food or without food? How many do I take? How often do I take it? If I hand you a box that has that thing in it, what is this? And so most people are thinking compression from the back over the uterus. This is compression of the pelvis. And so people are like, why can't I just get a belt or something to tie it down and just pull it, or a sacroiliac belt or some of these other non-technologically advanced devices, and you can't physically, through our research, all the research we've done, you can't physically tighten it yourself to enough pressure. So that's why the adjustable compression technology, a little extra ratcheting device. So you tighten it down as tight as you can get it, lay down, tighten it a little bit more, then use that ratcheting device that will ratchet, and that gives you enough compression. You just cannot physically tighten something, whether it's a sacral belt, sacroiliac belt, it doesn't do the same thing. It may look like it, but it just doesn't.
So help me understand, is it the laxity of the ligaments or the muscle? Because I've heard both.
Well,
both. So from a physiologic perspective, in terms of the pelvic structure, if you look at the pelvic basin, you have ligaments with muscle within that pelvic basin. So if you have relaxation of those ligaments, those muscles are going to be strained. So a lot of times what we will do at times is we will do some trigger point injections in the muscle to try to relax the spasms. Because what happens is you have relaxation that ends up contracting a little bit out of proportion.
And it could be a combination of everything. There's just no real way to isolate exactly what's causing somebody's pain. But if the uterus is contracting as a muscle and it's getting smaller as it contracts to express the tissue, it could be pulling on the muscles because the ligaments are loose, or it could be pulling on the ligaments itself that are chronically tight.
So remember, the uterus is suspended. It just doesn't float in the pelvis. It actually has the round ligaments that actually end in the inguinal canal right in front. So they're going to go right to the pelvic sidewall. And then you have the uterosacral ligaments, which go from the back of the uterus to the sacral promontory. And that's why we see so much back pain, especially when there's endometriosis on those uterosacral ligaments, because they're shortening and pulling. And we see that surgically. We give women results because we cut those ligaments and we take the disease out.
Okay. And if it's laxity of both ligaments and muscles, sort of roughly how much do you need before you start getting symptoms? Is it a 10%, a 20%?
How much
laxity?
We don't know.
Yeah.
We've never studied how much laxity or this laxity because it's such a non-invasive. There's no risk of injury. There's just no side effects. We put this on people and they're getting relief within 60 seconds. I mean, debilitating menstrual cramp pain, laying down, and tears come in their eyes because they've never had any relief before, let alone in 60 seconds. Whereas you take an NSAID or something, it's taking 20 to 40 minutes to kick in. So they're taking this 60 seconds, 90 seconds, relief is gone, or is there, and they lay down with it for 15, 20 minutes and then take it off and go about their day. So something.
And my last question, was the study you cited published?
I don't know if it was published, but it was through Sarasota Memorial Hospital, an IRB sanctioned event through a research that was done in Sarasota. We have it. I think we included, did we include the,
Yeah, we did.
the study in our paperwork? The research only had, well, we siphoned through 20 people and started with 12. One never showed up, one didn't finish, and so it was 10 people. Then
Since we're going to start picking on the study.
Sure.
A limited number of patients. How did you control? Did you have a sham device? What did you compare to? Were these people just with discomfort and you put it on and you had them answer all these questions? And again, I'm really interested in how did you control, and or was this just an observational thing?
No, it was they had patients that did medicine only, and these were all the same patients. So 1 month they did just their medicine, their normal routine, what they got relief from. Another month they used the device. Another month they put the device on but didn't tighten it down. So there was different variables that they did in order to, so that we can show that there was a clear delineation between when they used it, when they didn't use it, when they used the medicine, when they didn't use medicine. So they were off medication for 13 weeks prior to doing a study. So they were fresh and clear. Sure. Absolutely.
Yeah, okay.
Thank you for your time.
All right, agenda item number 16, application number 17.114, request to establish two new level 2 HCPCS codes to identify the Argus 2 retinal system. Our primary speaker is Mr. Stuart Langbein.
Good afternoon. My name is Stuart Langbein. I'm an attorney with the law firm of Hogan Lovells. I serve as outside reimbursement counsel to Second Sight and have no other financial connections with the company. I'm here to address the preliminary decision that was addressing the request for separate codes for two external components to the Argus 2 retinal prosthesis system. The preliminary decision was that the request for separate codes for the replacement items was not approved, and there were two rationales embedded in the preliminary decision from the work group. One, that there's an existing C code that was sufficient for the entire system. And then the second is that V2799, the miscellaneous vision item or service code, is available for assignment by insurers. So those were the two reasons for not approving the code requests, and we disagree with the preliminary decision, and for a few reasons, which I'll just note here and then explain in a little bit more detail. One is we're having trouble discerning the rationale for the decision, and I'll talk about that. The decision treats similarly situated products differently. There are a lot of products, replacement items that are related to a prosthetic device that have unique HCPCS codes, which is what we're seeking. We think that the suggested use of the V2799 code mischaracterizes the technology because it really labels it as a vision item or service when it's really related to a prosthetic device. And it's also the decision and suggestion to use V2799 is inconsistent with Medicare guidance on the applicable Medicare contractor that should be billed for the items and services. So for those reasons, which I'll expand on, we believe and ask the work group to revise the preliminary decision and to establish 2 new codes in the L8600 series. So let me just first start with an explanation of the Argus 2 retinal prosthesis system. The system has 3 components. There's a retinal implant, there's a head mount telemetry system, and a video processing unit. And if you look at the slide on the right side, you can see the glasses, what looks like glasses, that's the head mounted telemetry system. And in the middle there is the video processing unit, or the VPU. Those are 2 external components. What's not pictured is the implant, the retinal implant. So here's how the various components of the system work together. There's a video camera in the telemetry system that captures a scene. That video is then transferred down to the VPU. The VPU processes and transforms the video into instructions that are sent back up to the telemetry system. Those instructions are then transmitted wirelessly from the telemetry system to the implant in the head, and then the visual information once in there is transmitted along the optic nerve to the brain, and it creates the perception of patterns of light. And patients need to learn, and they undergo training to process what it means, what those patterns of light, how it translates into something that's in the field in front of them. So as I understand it, what a patient actually gets from the use of the system is quite variable, but it can include things like, and these are patients who have no vision. So what patients can experience with this system is some functional vision, the ability to detect light, the ability to follow lines in a crosswalk, see some letters, and also sensing motion. So hopefully that gives you a brief understanding of how these components work together to produce something tangible and beneficial for the individual with the system. So I mentioned earlier there are 3 components to the system. Those are all provided when the implant is done, which is typically in a hospital outpatient department. The patient goes away with, obviously, the implant, but then also a VPU and the telemetry system. So the entire system, the patient goes home with that. That's not part of this coding request. What's part of the coding request is a telemetry system and a VPU that will need to be replaced at some point after the patient is at home. Now, there's a 1-year warranty on these 2 external components, and they can last longer than a year. They can last for a couple of years, but like other systems where they're external components, they can need to be replaced. They may break or just over time wear out. And importantly, this system requires all 3 components to be working. If the VPU is not working, the patient's going to get nothing from having that implant. So in the preliminary decision, as I mentioned before, there were sort of 2 components to it. One is that there's an existing C code that describes internal and external components of the system. We don't disagree with that. That's what is billed by the hospital when the implant is done and when the patient leaves with the full system. That's initial, if you think about it that way. That's all the initial components. That's not an issue. We agree that code handles what the hospital needs for all components of the system to bill. But what we're talking about is the external, the replacement components. And the rationale that was given in the preliminary decision for the external components is that a code is not needed because V2799 is available is available for assignment by insurers. And I have to say we're scratching our heads a little bit at understanding the rationale there, because just because a miscellaneous code exists, that to me isn't a reason not to grant a code, because there's almost always a miscellaneous code that exists. And I know you considered, or was in the preliminary decisions from yesterday, just looking at one example of an elbow prosthesis. There's a miscellaneous code, L3999, for upper limb prosthesis not otherwise specified. That could have been an acceptable code for an elbow prosthesis, but the work group recommended a separate code for that item. So we're struggling a little bit with the concept of just because there's a miscellaneous code available, that shouldn't be a basis for denying the application. But there are other concerns that we have with the failure to create a code for these items. I mentioned earlier, it treats different products differently. As you know, the HCPCS code set includes many specific HCPCS codes for replacement items that are external components for implanted device. And in the materials that we provided in responding to the preliminary decision, we noted there are 40 plus replacement component codes for different items that have implanted products like cochlear implants, which you heard recently discussed, neurostimulators, you heard about the AOIs, not the cochlear implants, and ventricular assist devices. So, what we think is just like those situations, those many other codes where there's been an application that's been granted for a code for a replacement items, we think that there's as much of a need for replacement codes for the telemetry system and the VPU as there is for the other these other types of products like cochlear implants, neurostimulators, etc. Another problem that we have with the suggestion that V2799 is an appropriate code is it mischaracterizes the items as vision items, and that can lead to problems as people think it falls within a vision benefit. These items, the replacement for the VPU and the telemetry system, they fall within the prosthetic benefit. CMS has been very clear that the Argus 2 system itself and the implant is a prosthetic device. So these replacement items would be supplies that are necessary for the use of a prosthetic device, falling under the prosthetic benefit. In fact, the PDAC has issued coding guidance specifically on the Argus 2 system and has addressed the external components and identified them as prosthetics. So what we're concerned about is the idea of billing for these replacement items under V2799, that's going to create a confusion thinking that they're vision items and not prosthetics. Typically in the HCPCS level 2 system, you see a lot of devices, prosthetic devices and supplies having L codes rather than V codes. In addition, we're concerned about some confusion among the commercial payers, and there's a little bullet here on Oxford Health Plans, what their vision service policy is really for diagnostic and treatment services by ophthalmologists and optometrists. while they look at replacement items related to ocular implants as falling within a prosthetic device category. So again, it continues this theme of our concern that labeling this with a V code as a vision service rather than with some sort of code that's really reflective of something that falls within a prosthetic benefit. In addition, we're also concerned that the use of V2799 as suggested by the work group leads to a contractor jurisdictional conflict. The Medicare Benefit Policy Manual in Chapter 20, Section 10, says that replacement parts related to prosthetic devices must be billed to the AB max. In addition, there's the PDAC guidance that I mentioned before also says that for Argus 2 and the external components, those items have to be billed to the AB MAC. But if you look at CMS's 2017 DMEPOS jurisdiction list, it identifies V2799 as being billed to the Durable Medical Equipment MAC. So again, we think that the preliminary decision to use V2799 for these replacement codes would create an impropriety in claims processing, because it would say this code should go to the DME, claims for this code should go to the DME MAC, when CMS policy, and as confirmed by the PDAC, is it should go to the AB MACs. So for these reasons, we believe that the telemetry system in the VPU, when they're needed for replacement, that they should have replacement codes in the L8600 series. That's where the codes, the replacement codes are for components related to cochlear implants, neurostimulators, et cetera. And we note that I mentioned before that VADs also have replacement items and codes. Those codes are in the Q code, in the Q section. And that's as you know, that's a temporary national code. So we've just think that the L8600 series is more appropriate because those are permanent national codes rather than temporary national codes. But I think we'd be amenable to Q codes if that's what the work group decided. We also think that the other benefit of using the L8600 series is all of those codes in the DMEPOS 2017 DMEPOS jurisdiction list. They all track to billing to the AB MAC and not the DME MAC. So we think it would solve that jurisdictional issue as well. So in conclusion, for the reasons that I've gone through, we don't agree with the preliminary decision, and we ask that the work group revise its preliminary decision and create two codes in the L8600 series, one replacement code for the telemetry system, and one replacement code for the VPU. And I'd be happy to take any questions.
How many of these devices have been implanted?
I'd like to ask somebody from the company who can give you a more specific answer than that. So Trina, if you wouldn't mind addressing that.
Yes, my name is Trina Holmes. I'm the reimbursement manager for Second Sight Medical Products. We currently have 62 implants in the United States.
So your application says 53. I was going to offer an answer to that question. So I guess you've been busy.
Yes. So we've had more surgery since our application.
So, so 62 sold since the FDA clearance in 2013?
Yes.
Total in the U.S., or does any of those 62 include outside of the U.S. that you were
No,
mentioning?
62 is just in the United States.
Okay. And for any of those that are still in use, so you must have some dropout rate for a variety of reasons, that are still in use and where a replacement component has been provided, have you had any specific issues you can tell us about with the AB Max not paying?
Stuart, can you
What she's asking about is issues with the Medicare contractors not paying for the replacement items.
Okay, so for the replacement items, we don't bill for the replacement items. Since we've only been given the miscellaneous code, our patients are under a warranty. So basically, they're under a warranty for 5 years where they get their replacements and upgrades for free of charge, but we cannot continue to do that due to the price of the VPU and the glasses. And so once these patients reach out of their 5 years, we will have to bill the patient and their payer for the VPU and glasses.
And let me clarify, I think that 5 years, those are clinical study related patients. So a lot of the patients, and correct me if I'm wrong, Trina, but a lot of the patients that are in the number, that 60-62, stem from the clinical trial. So as part of the clinical trial, there was a 5-year period, but the items are warranted for a year. That 5 year is not, it's not like an ongoing business practice. It's really just a component of the initial clinical study.
That's correct. And so we have over half of our patients who are now out of the warranty from when they what we call a warranty, but not what you would call a 1-year warranty. They're out of our 5-year time frame from the time they were implanted in the clinical trial.
So assuming half of the whole population that got them are still using them, in fact, and haven't dropped out, half of that would be 31 patients nationwide that are now out of warranty?
Yes, last time I spoke to our customer service department, we're somewhere between 28 to 31 people. I don't have an exact number with me, but somewhere between 28 to 31 people who are now out of their warranty from the time that they were implanted in the clinical trial.
Right, and how many replacements have been made for those people or needed, and of those, do you know how many of them would be billing Medicare?
Stuart, do you have the number for the VPU replacement and the telemetry replacement? Was it 17 and 52 or?
That sounds right, and we can follow up with those numbers. I mean, look, this is a very small patient population to begin with. These numbers, we recognize that you often look at volume in making your decisions, but I'd also ask you to consider the fact that CMS has created a C code. They make payment for this system, and then the idea is that it will be used for a long period of time. Well, if you go 2 years and either the VPU or the telemetry system is no longer working because a patient drops it or for whatever reason, that invalidates the whole use of the system. So CMS created a code, created the C1841 code to pay on the hospital outpatient side. So in order for that to continue, that system and what Medicare has invested in for this patient to continue to be of any use, just like many other devices like the AOIs and the cochlear implants, we think there needs to be payment for the replacement item, and there needs to be a code to do that. So we recognize volume. We're never going to be able to stand up here, or I don't think we're ever going to be able to stand up here and tell you a volume number that's going to say, oh, I really feel comfortable as a member of the work group that that's a significant enough volume. But it's a significant enough service that Medicare has already invested in by creating a code that we think it's important to be able to ensure that beneficiaries who have this system can continue to use it by getting the replacement items that they need.
Do you have any information that these patients, particularly Medicare, because you bring that up as a claims processing issue, have not gotten their replacement devices or that they've not been paid?
They have been provided free of charge to them. So we don't have anything to bill because we can't even go through our, so when we were trying to do the accreditation to become a DMEPOS supplier to be able to bill that ourselves, we can't even get through accreditation because we don't have a valid code to bill the glasses and the VPU. They will not allow us to use V2799 because it goes to the wrong ABMAC or DMEMAC as Stewart addressed. We couldn't finish the accreditation process to be a DMEPOS supplier because we need separate codes for the externals.
I think part of the problem is because of a lack of code and the fact that the initial system is provided by a hospital that knows the code and the payment rate they're going to get. For these replacement items, you need a supplier. You need a DMEPOS supplier. The company has encountered some problems, and I think we mentioned those in the application, in themselves becoming a DMEPOS supplier. But whether it's them or another entity supplying these items, the lack of a code has been very problematic. So the company has basically, I believe, foot the bill, and is trying to no longer do that. It's not really sustainable. So that's really the effort here, and I think that's the best answer we can offer.
And just to make clear, the V codes aren't just for vision. There's a eye prosthesis policy, and those are all V codes.
Yeah, and I understand that that's the way it's described, and I was just reporting what we've encountered a little bit in the field and what we're concerned about, that the perception, whether it's really a true and accurate understanding of the HCPCS code set, we don't know, but we're experiencing it. We've seen it as a problem in dealing with insurers and payers. Anything else? Thank you.
Agenda item number 17, application number 17.64, request to establish a series of 5 new level 2 HCPCS codes to identify the Brainport V100. There are no speakers for this item. Are there any comments or concerns? All right, our final agenda item of today, agenda item number 18, application number 17.117, request to establish a new level 2 HCPCS code to identify the Freedom arm cover, to establish a new level 2 HCPCS code to identify the JFO, to assign existing code L2820 to the JFO pad, and to assign existing codes L5704 and L5705 to the JFO. Our primary speaker is Mr. James DeVito.
My name is James DeVito. I am the owner of JAFO, so I have a pretty big financial connection with the company. I've been sitting in the back all day, and I realized that you guys are very impressive, and I hate saying that I don't agree with any decisions that you made. But before I start, I just want to explain the chronology of the JAFO. My first AFO was this plastic, I guess it's a a plastic. It was hard, it was uncomfortable, and it was painfully chafing, and it broke many times at what I like to call the not so sweet spot right here. So in 2002, I came up with this product. Kind of looks like a baloney amputee prosthetic leg cover. I put a zipper in the front, and the posterior I put a chute, so the AFO slides up into the chute here. And then I got some silicone cover, rolled it on, so it kind of looks like your leg. So no one knew I had AFOs on for many years. In 2010, I filed for utility and design patent, and I looked for alternative material, And that's when I decided to go with a 1/8 inch neoprene cover. So many people and companies began recognizing the importance of this, and as a matter of fact, Allard offered to buy the company, and I turned them down. So I decided to apply for the application to Medicare, which brought me here today. So this presentation will show the existing CMS codes and the case for the JAFO. The JAFO is more than an A4467. Its importance is more than a belt, strap, sleeve, garment, or covering. I don't think I explained myself properly in the application process, so that's why I'm here today. So I was going through other products, and I kind of noticed that the E0731 conductive garment for TENS unit, it's kind of similar to the JAFO in that it's defined as a conductive garment covering, protects and keeps the TENS unit in place while working as a conductor due to the silver threads that are sewn inside the garment. The JAFO is also a garment that protects and keeps the AFO in place while eliminating chafing due to the chute that's sewn on the inside of the garment. This is a free flow AFO, the one that I have there with the molds and everything. And I was just assigned the CE mark for sale in the UK too, which was difficult. That took about a year. So the JAFO requested to establish a new level 2 code and also an add-on code to all ankle-foot orthotics. JAFO is an alternative method and a new concept that successfully secures AFOs without the use of a cuff, hard boot, or Velcro strap. It reduces the risk of breaking the AFO strut at the not-so-sweet spot, and it also eliminates chafing 100%. That's been a huge problem for anyone that wears an AFO, is the chafing. It eliminates peroneal nerve entrapment, increases proprioception and balance, and protects the patient's atrophied limb and ankle-foot orthotic from external forces. So I guess the best code that most people here probably know is the L1932, the AFO rigid anterior tibial carbon fiber. When you get an AFO, it has a strap. It's usually very unforgiving, and after some time, both the brace and the strap end up failing. Replacement of carbon fiber AFOs is the most expensive cost to Medicare. New AFO straps, they are, like I said, very unforgiving, and they cause the carbon fiber brace to snap because of the strain to the brace. On the flip side, after 6 months, you probably have to get a new strap, which also costs money and time from the clinician. And a lot of times you could actually fall out of your AFO and while you're walking, and you can get hurt. So the JAFO will eliminate the need to replace the straps, and the 1/8 inch neoprene has just the right amount of play that allows the patient to bend without snapping the brace at the not-so-sweet spot, which is what I called it. So JAFO is requesting an add-on code as an alternative method for attaching AFOs to prevent brace failure and eliminate strap replacement. The blue rocker is another AFO. This one here. There's another one that comes down all the way like this. So this is really hard, and the two straps in the back here, when you bend, there's no forgiving on this, and this thing always snaps. And this is like $1,000, $1,200, very expensive. So the patients are constantly going in and replacing them. So if you wear the JAFO, you don't need a strap, and the chances of the AFO breaking down have drastically reduced with just that invention there. So not only does a strap lose its grip, and not only does it increase the chances of brace failure, but they all chafe, like I just mentioned in the beginning. Custom fabricated and prefab AFOs all use a strap to secure the plastic carbon fiber, strut, and footplate, and they're very uncomfortable and they're damaging to the limb over time. So I probably missed a couple of codes in there, but as you can see, at the end of the day, the only thing they have in common is they need to be strapped somehow, and that is with the Velcro. I'm wearing a carbon fiber AFO fabricated by Kinetic Research. And I'm just going to show you the difference here. Step away from the mic. You can see that when you bend, this kind of pulls away from the leg a little bit, but it's still attached down here. especially if you're an active person like myself. I went through many AFOs before I started figuring out that this is the best way to go. The second point, obviously, is the chafing. Because when you're walking, the AFO slides up and down. It creates a red mark and chafing. But as you walk with the JAFO, the strut slides a little bit up and down inside the posterior chute. And it's kind of like a piston in a car where the block stays stable while the piston goes up and down. Same concept. So let me just take it over a second here. See, I'm very active for you. So some of these AFOs, they'll come with the cuff. We'll get to that in a moment. So here's the cuff. Notice there's no padding on that cuff. Oh, that might work. Sorry. Oh, yeah, I don't want to get that loud noise thing. Thank you. Another code I'd like to discuss is, regarding the padding, is L2820. It's a soft interface code. When you have the JAFO, the soft interface is the chute that's in the back here. So there's really no need to pad the AFO strut anymore, because this acts as an interface between the leg and the AFO. Unfortunately, I wasn't able to code that because this never existed before, and so I believe that it should be considered a little bit for that. A lot of times orthotists pad out the foot plate, and I just think that, I don't know why they do it, to be honest with you. Any good mold of a foot like this one ends up, if you put padding in, it lifts your foot in the shoe, and the top of your toes and the top of your foot get very red, and it's so uncomfortable you can't wear them. So if you were to use the JAFO, realistically you could get rid of L2820 altogether if it's a custom fabricated AFO. You don't need to pad this, you don't need to pad this, and you don't need to pad that. So over the years, Kinetic Research, Maramed, Turbomed, they have many years of experience, knowledge, and they're highly respected in the O&P industry. They make prefab and custom fab AFOs, and they've changed lives. I've seen it over the past 16 years. All three of the companies fully endorse the product. They actually even sell them as, offer them to the clients as an alternative strapping technique. Patients always say, wow, I can't believe I could wear the AFO all day now. I'm like, that's great. You know, they could walk further. They could run faster. All those things make me very happy to hear. So here's another AFO called the Turbomed. This AFO is pretty neat. This goes outside the shoe, so you don't need a foot plate anymore. And this is the same concept too. This also has a cuff. And you can see that that cuff also doesn't need any padding. Whereas before, it does, and they always file for L2820, and they get paid all the time. So the JAFO can last you 5 years. Yeah, I've been wearing the same one for a very long time. I have different colors, different patterns, but at the end of the day, I still wear a lot of them. Here's just some of the clients. I mean, I have sold probably about 200 of them in the United States. I have not had one return. At the end of the day, everyone really likes it. They say, I live a much better life with it. So it's one of the reasons why I decided to come and apply today. I'll show you the patent too. In 2010, I filed for it. In 2012, I got it. So it's the neoprene sleeve with the chute. I also have a chute in the front for AFOs that go up the front with a zipper in the back. So there's one right there. The chute's in the front, zipper's in the back. And that was issued, that took about 2 years. I also have a design patent on it. So the fourth item was the AFO strap can cut off the blood supply, and it could become counterproductive wearing it. Sometimes it even makes it worse, and that's called the perennial nerve entrapment. So what the JAFO is great at doing, it basically redistributes the pressure from an AFO strap. So instead of blocking or trapping the nerve, now it has a good free flow of blood that can pass without having any strapping techniques. How much? No way. The compression too is the fifth one that I wanted to say, that for proprioception and balance, that having that around your leg makes anyone with neuropathy like myself feel much better. Having just a strap really irritated my nerves. And the last thing I wanted to mention is that I believe that covering a human limb and an orthotic is more important than covering just a BK prosthetic leg. So you have carbon fiber and a titanium pylon, and that's usually covered by this. And this is paid right now on the L5705. And I guess, I'd like to request that JAFO also is considered as a orthotic cover and limb cover. Because remember, I could actually wear this without the AFO, and that helped me for blood supply to my feet. The doctors almost thought about amputating both of my legs, and then when I started wearing the compression sleeve from the JAFO, after 6 months, they said, you know what, we think that that helped you very much. And I noticed there were a lot of people here today speaking about compression garments. So I just wanted to make the point that, now that hopefully I explained it, which I don't think I did a very good job, I get nervous sometimes, but I'm hopefully going to ask that you guys reconsider that it's not just an A4467, it's much more than that. And it does save Medicare a lot of money, and it helps patients. And at the end of the day, that's, I guess, what we're here for. So, thank you. Oh, stole it. Oh, you tricked me. Okay, thanks, guys.
At the beginning of the meeting. All right, we've concluded our agenda. We'd like to thank you for coming out, for taking time out of your schedules to appear here today, to give us all of your valuable input. We really appreciate it. We'll see you next year. Have a safe travel home.